Thank you so much for joining us. Our presentation will begin shortly. So we want to thank you on behalf of the Education Committees of Healthcare for All Minnesota and Physicians for a National Health Program, the Minnesota chapter. My name is Jen Crawford. I'm the administrator for PNHP Minnesota, and I'll be filling in for Dana tonight. For anyone who's unfamiliar with Zoom, we're just going to go through a couple of things before we begin tonight, just so everybody can interact with and enjoy the presentation as best as they can. You'll notice at the top of your screen that there's an option that says View Options. Feel free to use that if at any point you can't see the presentation. If you just adjust that, that should give you a better view. There is also a button at the bottom of the screen that says Chat. If you'd like, you can open that now. It will open a new window for you. That is how we're going to submit questions this evening. During our presentation, feel free if you have a question for our presenter or, oh, somebody's having a hard time hearing me. Oh, I don't have any music on. That's so strange. I'm so sorry. Here, let me pull you closer. I apologize if you're having a hard time hearing me. So with the chat, I promise I have no music on. With the chat, put in your questions there for our presenter or the organizers if you have any questions. You'll notice at the top of the chat, there is a blue link. Please feel free to click that link now. That is our sign-in form, just so we can see everybody that's here with us tonight. And again, we thank you so much for filling that out so that we can keep track of everybody and follow up. After the presentation tonight, we will be sending out a recording of the presentation. Thanks, Mark, along with notes. So if you have any follow-up questions, you can email us back, or you can share those with family and friends, including the presentation itself and a link to the video. So tonight our presentation is going to go until about 8 o'clock. And now it is my pleasure to introduce Ann Jones, retired nurse and vice chair of Healthcare for All Minnesota.
Thank you, Jen, and welcome everybody. Our agenda this evening is, I'll get us started with just a little bit of background on our topic for this evening. Dr. Mark Brockie will introduce our speaker for this evening. You'll hear from Dr. John Nyman on health economists. And I have a few announcements at the end. Jen will come back with a wrap up and some post-meeting information. The purpose of our program this evening is on the subject of cost studies. And for those of you who've joined us on a couple of other events, this is a third presentation that we've done on the subject of cost studies and analyses of major studies of the cost of Medicare for all that have been published and get talked about quite a bit. We know if you've talked with anyone and advocated fixing how we pay for healthcare in this country, that the most common question for advocates of healthcare payment reform is some variation on, well, what's that going to cost? Or all that sounds really great, but how are you going to pay for it? We want you to have the best information available on the expected cost of a single payer Medicare for all system for the US, as well as the confidence to explain the cost and importantly, the benefits of fixing how we pay for healthcare. We need our advocates and activists for reform to be able to rebut the deliberate disinformation often used by opponents of reform on costs. And next, I will turn this over to Dr. Mark Brockie, who will introduce our speaker. Dr. Brockie is the chair of Healthcare for All Minnesota. Dr. Brockie, you'll need to unmute yourself.
Thank you, Ann. Missed that little piece. I want to thank all of those who have signed on to watch our program. It is my real pleasure this evening to introduce our speaker, Dr. John Nyman. Dr. Nyman has his PhD in economics from the University of Wisconsin-Madison. He recently retired from the University of Minnesota Division of Health Policy and Management, just in time for the COVID-19 lockdown. He has done work in the areas of nursing home policy, physician behavior, health insurance, and cost effectiveness analysis. He has even written papers on why people gamble recreationally, but we're not studying that tonight. In addition to authoring over 150 research articles and a couple of books, Dr. Nyman has received awards for excellence in teaching. This evening, as Ann mentioned, Dr. Nyman will be talking to us about his paper comparing a number of recent studies which ask the question, how much will it cost to have Medicare for all? Dr. Nyman?
Myself here. Can you hear me now? Let's see.
Yes, Dr. Nyman, we can hear you well.
All right. I'll get these slides up. All right. Thank you again, Mark. As you said, I'm actually a professor emeritus at the University of Minnesota. And I retired in 2019, about 2.5 years ago, I guess. And it's been about that long since I've given a talk. And so I'm a little rusty, and I hope that I don't embarrass myself too badly in doing this. I apologize in advance if there's issues. Let's see. The article that Mark was talking about is this one. It was published just earlier this year in Applied Health Economics and Health Policy. There's they have open policy, and so you can buy the article. Unfortunately, I don't even have an article to send out. They haven't given me one other than the galleys. But that's a website where you can find that article. I'm sure a lot of you people have seen this cover of the New Yorker. Here's this girl, she's on a date or social situation. She looks great from the top up. And from the bottom down, she's got jogging shorts on, bunny slippers, it looks like, a cat. She's got a screen in front of the back so that you can't see the rest of the mess that's in her bedroom. Well, this works not only for people on dates like this, but it certainly also works for people giving talks. So I'll let you think about that. Anyway, these are numbers that a lot of you know. There's over 30 million Americans that are uninsured, and many of the people are underinsured, which means that they have cost-sharing provisions that make access to healthcare unaffordable. Per capita spending in the United States is far higher than it is in other countries. And for these reasons and a number of others, Congress is considering a form of single payer called Medicare for All. And of course, the big question for economists is, well, what will it cost? There's a couple of bills before Congress right now on which most of these studies are based. One of them is in the House. That's Jayapal's bill, HR 1384, and then Sanders' bill 1129. And as you know, at present, Medicare covers only medical care and drugs and some long-term care for those people who are over 65 and for those with kidney disease or ALS, and those receiving Social Security disability benefits. And it has major cost-sharing provisions. What Medicare for All would do is it would cover all citizens, all residents automatically. Private insurance would be eliminated. It would cover all the services needed to diagnose or treat or rehabilitate a condition, which includes the physician services, hospital procedures, prescription drugs, mental health, substance abuse, dental, vision care, long-term care services. There would be no cost sharing. There's been a number of articles published, and not published, but well, they are published. A lot of them, though, appear in the gray literature, which is, these are reports that come out of an institute of some sort. And in fact, only one of these has been published in the peer-reviewed literature. Gordon Mosser did a review of a New York, well, there was a New York Times review that he used, and he looked into the reference papers referenced by the New York Times and looked for other sources and found this series of 6 different articles. And these are the ones that I have reviewed in this paper. The criteria for inclusion was that they came out of some sort of an academic or academic-like institution like RAND. They were national in scope. They didn't only concentrate on a certain state. They were published sometime since 2016. 2016 was when these bills became part of the conversation. And they estimated the 1-year change in costs. There was a paper that estimated the 10-year changes in cost, but there wasn't enough information for me to actually include this because I didn't know how they aggregated over these 10 years. And you can't really divide just whatever it is by 10 because you don't know what's happening to growth of the utilization over time. So I had to exclude that. The problem is that the findings range from a cost savings of about 20% to a cost increase of almost 17%. And the problem is that with this large and inconsistent, including both savings and increases, it makes it really difficult to predict what would happen if you actually implemented Medicare for All. So this paper is going to look at these 6 studies, but it's going to try to correct what I regard as mistakes. Some of them are analytical mistakes. They made the wrong decisions about how to incorporate some of the information. Some of them are empirically unsupportable assumptions. And then some of them are inconsistencies across the bills, or I'm sorry, inconsistencies with the bills. It's not the issue of inconsistencies across the papers that's as much of a concern. There are some of the papers that might include savings for reduced fraud and abuse. That's fine, and some others might not. That's part of how you sort of decide how you're going to do this. But if there was inconsistencies with the bill, if the bill decided to cover something that wasn't in the savings or in the expenditures that of the paper of the study, then I think that's a problem, and I tried to correct for that. And we used as a baseline, or I used as a baseline, each report's own estimate of the national health spending under the current system in the year of comparison. The year of comparison varied a lot from, I think, 2017 to 2021 or 2022. And what I tried to do is I tried to find the corrected 1-year percentage change from that baseline if Medicare for All were adopted. And in order to do this, I disaggregated the costs into 5 components. One of them was utilization. And utilization, to think about how to do this, is you would not only count the number of office visits and the number of hospitalizations, but you'd have to weight those by the prices that are in effect at the time. And so you have weighted average costs, and then you try to just change the utilization, holding the prices constant. And so that's the utilization figure that I hope came out of these studies. The next one would be the medical and hospital unit prices, the effect of changing that on total spending. And with that, you have to consider the idea that if you implement Medicare for all, it's probably going to reduce prices with regard to private prices, but it might raise prices compared with Medicaid prices. Drug prices, the effect of Medicare for all on drug prices. When I started teaching health economics, which was probably almost 40 years ago, I used to tell my students that there was no bigger bargain out there than drugs. They were super effective, and they really cost very, very little. Well, I think that the drug companies were listening to these lectures, and so they've been raising prices, and especially so in the last 10 to 15 years. And so that the drug prices, there'd be an effect on drug prices, negotiating those prices down. Insurer administrative costs, this is the costs that the private insurers have for claims processing, for paying their agents, for overhead, that sort of thing. And it also includes profits. And so this really represents a very sizable amount of costs. Himmelstein and Woolhandler estimate that at over 12%. There's estimates that are around that by other people too. And so this would be the impact of Medicare for all on changing from private administrative costs to a Medicaid administrative costs. And the last one that I disaggregated here is this business and insurance related administrative costs. This refers to the costs that hospitals and physicians' clinics have in trying to deal with the insurance industry. And the insurers want to reduce the number of payments that they make. And so there's a lot of tension a lot of times, and there's a lot of people that are employed by hospitals and clinics trying to get the money out that the clinics and hospitals need to operate from the insurance companies. And so this really does represent a large cost. There's been a number of studies that have been done to try to estimate that. One of them that was done in California estimated that, this is by a guy named James Kahn and some of his colleagues, estimated that at about 20% of total costs. What I want to do here is focus on the long-term or steady state. I'm still interested in the 1 year, but long-term steady state, which means that I don't include anything about the transition costs, trying to retrain people who are working in the insurance industry for other jobs, that sort of thing. And I also want to eliminate supply constraints. And by supply constraints, these are constraints that have been assumed by a couple of the studies that say that you're not going to get as much spending as you would based on demand, because there just aren't enough hospital beds, or there just aren't enough physicians or other providers to provide the care that is needed. And so those supply constraints would constrain the amount of spending. So without further ado, we'll go to the reports. There's 6 of them. But I guess first I need to talk about the definitions of baseline spending. These are definitions that are kind of official. They come out of CMS. One of them is the national health expenditures. It's the broadest. It includes personal health expenditures, and that's hospital, physician, dental, home care, nursing home, drugs, durable medical equipment, and other means, things like ambulance care and ambulance services and that sort of thing. And then if you add to that administrative and insurance costs and public health, and then investment as research and new structures and equipment, then those three items together, personal health expenditures and those other two, would represent national health expenditures. Another concept that people use is health consumption expenditures, and that's the personal health expenditures plus the administrative insurance costs and public health. And what I'm going to do is I will tell you what they use as their measure of expenditures, but I'm going to a lot of times just talk in general about national health spending, or just spending, my term, and that'll encompass all these. There's actually three of them that are used in these studies, the three different measures of total spending. So here's the first of the studies. It's the one by Blahous. It came out of George Mason University in 2018. With regard to utilization, he thinks that utilization would increase with Medicare for All by about 11.3%. And that's because there'd be the covering of the uninsured. The eliminating of cost sharing, which would increase the number of services each person might consume on average. And then these additional new services that are covered by Medicare for All that weren't covered under the Medicare, existing Medicare program, things like long-term care, all long-term care services, dental services, and that sort of thing. So when you think about the total, this is just the utilization part, that would translate to about a 9.5 increase in total national health expenditures, NHE. Paying providers at the Medicare rates would decrease national health expenditures by 9.5%. Drug prices, negotiating them, would decrease them by 1.3%. Administrative costs are assumed to be 6% of total spending, and that would generate the difference between what they are now and 6% now would generate savings of 1.8%. Saving from lower BIR costs weren't included, and so the total savings in national health expenditures would be about $83 billion, or 2%, based on 2022 national health expenditures. The report by Pollin and his co-workers there came out of the University of Massachusetts Amherst in 2018 again. Medicare for All would increase, and he uses, instead of national health expenditures, he uses health consumption expenditures, HCE. The utilization would increase that by 12%. Paying providers Medicaid rates would decrease spending by 3.1%. Negotiating drug prices would decrease spending by another 6.6%. The costs of administrating the Medicare for All was assumed to fall from where it is now to 3.5%, and that would produce savings of 5.6%. The BIR costs would be lower, and that would generate 4.5% savings. He also includes, and his colleagues, reduced waste and fraud at 1.7% savings. This was something that he thought would happen. I included that, even though not all the other estimates include that. Annual savings from adopting Medicare for All are going to be $390 billion, he estimates, or about 9.6% of baseline Again, it's health consumption expenditures from 2017. 2019 report from the Hopbrook Institute. This is done by Friedman. He thinks that utilization would be increased by 13.9%, resulting in about a 10.5% increase in baseline. And he uses personal health expenditures plus insurance administration. So this is kind of a hybrid type of measure of expenditures. It's just the personal health expenditures, the ones, you know, hospital and physician and dental and that sort of thing, plus the insurance administration. It doesn't include the public health spending that might include, or nor does it include in investment. If you apply the Medicare rates for a physician, or the Medicare rates plus 10% for hospitals, and negotiate drug prices, all those things together would decrease baseline spending by 18%. The administrative expense would decrease to 2%. And it would generate 7.2% savings from baseline. There would be lower BIR costs, business and insurance related costs, representing a 5.3% of baseline savings. And then overall, you'd have 720 billion, or 20% reduction in the 2019 baseline PHE plus administrative spending. One of the unusual reports was the one by Holahan, and it was unusual. It came out of the Urban Institute. The Urban Institute has a micro-simulation model that they use in a lot of things, and that was used to estimate the effects of Medicare for All. A micro-simulation model takes a group of people, a huge number of people, and then tries to determine how each person, that's the micro part, would respond to the different changes. Most of them are related to the price. If you get rid of cost sharing, or if you have a zero price where you were uninsured before and were paying, you know, the whole price, what effect would that have on spending? And that would be you know, determined by this model. There would be other things that you'd have to include in addition to that to account for those things that, like administration and the other costs that really you can't put into this micro sim model. But the advantage of this is that it can take into account a lot of the interactions among the variables, and there are often contradictory effects. However, the problem is it's not transparent because we really can't see how these components that we've been talking about change with the imposition of Medicare for All. And all these changes are going to be hidden. We really don't have a very good way of evaluating whether any of these things really make sense or are reasonable. The thing that they determined for utilization is they tried to estimate the effect of Medicare for All on utilization for the non-elderly, both the insured and the uninsured, responding to becoming insured and to the absence of cost sharing. How the existing Medicare elderly would respond to the absence of cost sharing, and then how long-term care recipients would be responding to Medicare for All coverage. The Holahan report had a supply constraint. In other words, they assumed that even if they have these changes in demand, it would run against shortages. There'd be not enough hospital beds to fulfill the demand, or not enough physicians to take care of these people. There'd be waiting lines. And the model would include changes due to paying physicians Medicare rates, physicians or hospitals at the Medicare level plus 12.4%, negotiating drug prices. They assumed a 6% administrative cost for insurance administration, and they didn't mention BIR costs at all. And overall, they had the highest amount of spending. It was an increase of 518.9 billion, or by 16.9% over their 2017 baseline national health expenditure. The report by Liu and Eibner comes out of Rand Corporation in 2019. They also had a supply constraint in there. They said 50% of the additional utilization would be not experienced because of the supplies constraint. And what we did was we used the unconstrained estimates, because we thought that'd be a better estimate, better estimate of the steady state 1-year costs. For that, the healthcare expenditures increased by 15%, which meant that national health expenditures would be increasing by 11.7% from their baseline. They assumed that Medicare for All would pay physicians the Medicare rate plus 7%, and the hospitals would pay the Medicare rate plus 24%. And they concluded from that on average, we assumed the payment levels would be about the same as they are in the status quo baseline in 2019. In other words, they eliminated any effect from lower prices for physicians and hospitals. The savings from the drug prices, they estimated a small amount, 39 billion, or about 1% reduction in national health expenditures. They assumed that administrative costs would be 6%, resulting in national health expenditure savings of 2.5%. BIR costs were estimated to reduce baseline spending by 1.6%. And without this, the 50% supply constraint, they estimated that Medicare costs would increase by 374 billion, or by about 9.8% of the 2019 baseline national health expenditures. This, if you didn't have this supply constraint, the spending would increase, but only by about 1.8%. So this is the one that I think is the one that is most comparable, because what we're trying to do is estimate what it would be in the steady state after all the changes and after the shakedown cruise has actually happened. The last one is this Galvani paper, and it's the only one to be peer reviewed. Utilization would increase by $100 billion, or 6.2%, for physicians and hospital expenditures, which represents about 2.9% of baseline. Prices, Medicare rates would reduce a physician by 1.3 and hospital expenditures by 1.6. Negotiating drug prices would save 5.6. Insurer administrative costs would fall to 2.2%, and that would result in savings of 6.3% of national health expenditures. BRR savings are estimated at 284 billion. In addition, in this report, they eliminated uncollected hospital fees. Now that would increase the expenditures if you eliminated that with Medicare for All. They also substituted office visits for ER visits for routine care. That would reduce expenditures, and reducing fraud would also reduce expenditures. So overall, they estimate that the national health expenditures would decrease by $458 billion, or by about 13.1%, using the 2017 baseline. So the evaluation is next. The next table, or the table I'm going to show you here, is shows the change in the total national spending in row 3, and it shows the range that we talked about originally, from 20% savings to 16.9%. And again, the issue is that with such a large range, you really don't know what to make out of it and what to expect. And so what I'd like to do next now is to critically evaluate the reports according to the cost components that I talked about. Here's the table, and you can see at the top there, those are the estimates. It shows what was used to measure spending and what year it was and what numbers they used for that. And then the second row is shows the estimated 1-year national spending after Medicare for All was imposed. And then so the third row there shows the one that they reported in their studies. This is the one that they expected to have. And it ranges from a savings of 20% to an increase in the plus 16.9%. Now, the first two things I'd like to talk about are, how you deal with the business and insurance-related costs and the Medicare for All administrative cost assumptions for the insurance companies, the rows 4 and 5. With regard to the BIR costs, the Pollin, the Friedman, and the Liu and Eibner and Galvani all calculate savings that are due to reduced BIR costs. The BIR costs occur because the physicians and hospitals don't have to deal with the insurance companies anymore. So this is a change in costs, but and it's a real one. But what Pollin and Friedman and Liu and Eibner go on to do is they go on to reduce the overall national health expenditures by these amounts, and that's wrong. These savings really do exist, but they wouldn't reduce the payments from Medicare for All. Those payments are only established by what the amounts are. If there's savings and costs from having less BIR expenditures, that's going to mean that the hospitals and the clinics are going to be able to make more money given the whatever is being paid them, but it's not going to reduce any of the amount that is paid from Medicare for All. So what we need to do then is to make an adjustment for the BIR savings and increase spending by these amounts for the Pollin and Friedman and Liu and Eibner articles. Now, Galvani also estimated what those BIR savings was, but she didn't use those numbers and subtract them from spending in order to increase the savings. So those are the numbers there that I have to put back in, and it's right here. It's, again, it's 4. You can see row 4 that here there's the change that would have existed that has to be eliminated. And then here's the existing estimates of what the administrative costs would be for the insurance companies. And our own Kip Sullivan found that if Medicare costs include the administrative costs and profits of the private insurers that administer Part C, a part of Medicare, those costs would average about 6%. But if they included only the administrative costs of the parts that actually were administered by Medicare, and none of the costs that were of the Medicare Part C, they'd average about 1.5%. And Medicare for All would be administered only by Medicare. So really the right number to think about is this 1.5 number. Now, Friedman, Galvani, and Pollin, they use larger numbers, but they sort of justify them in various ways. But the ones that are too high are the Blahous, Liu and Eibner, and the Holahan, because they mistakenly use the 6% that represents not only Medicare costs, but the part of the Medicare costs that is determined by the private payers that run or that participate in Part C. So the Pollin, the Friedman, and the Galvani assumptions generate savings of that amount, and they average about 6.3%. Blahous, Liu and Eibner assumptions generate only savings of 1.8 and 2.5. And so what I did was I substituted the 6.37 savings for the lower amounts, and that increased the savings for the Blahous by 229 billion, and Liu and Eibner increased their savings by 148 billion. So those are, let's see, these are the 6 here shows what the original numbers are, and I'll show you later on in the next table what the new numbers are. With regard to the prices, these are the assumptions for prices for the physician payments, for hospital payments, and then sometimes both of those things combined. Most of the reports assume prices to be set at a Medicare rate, but Friedman adds to that 10% for hospitals. And generally we can think of those prices, the new prices, as being larger, higher prices compared to those people who are currently paid under Medicaid, and then lower prices and considerably lower prices for those that are being paid for by the private insurers. Liu and Eibner, of course, say that their assumptions means that the prices are essentially unchanged, but there's a couple of problems with that. First, if you look at national healthcare systems in the developed countries, in the G7 countries, the countries that are the most like us, Canada, Japan, Italy, France, the UK, and Germany, their per capita spending averaged about $4,693 in 2019. Ours in the United States was over twice that. And the utilization per capita in those countries far exceeds. It's almost twice as much as in the United States. And much of this reduction, people have done analysis of these things, and much of the reduction has been due to lower unit payments, lower prices. There's a famous paper by Anderson and his colleagues written in 2009 that talk about these differences, and the title of it is "It's the Price is Stupid," meaning that this is an obvious thing, and that people have just overlooked the impact of prices. The second issue is that if you didn't, if you had no price change and you opted or you changed to Medicare for All, this would mean windfall profits possibly for some people, because there would be savings of 8.1% just for the BIR costs alone. And so I conclude that the Liu and Eibner number of 9.3% 8% in spending is likely due to this constant price assumption. The other one that has a price issue is the price issue, or the study by Friedman, and he assumes that there's a 20% reduction in spending that's due to prices, and that would result in an 18% reduction in overall spending. If you look at the other papers, the papers by Blahous, Pollin, and Galvani, their numbers are really consistent as to the effect of prices, 9.7, 9.7, and 9.1, and they average to 9.5. And what I did was I just, again, substituted these, I'm sorry, I'm going to go back up here, substituted 9.5 in for the other numbers and came up with what the new spending would be. But before I show you that, I go on to the issue of utilization, Medicare for all, the different bills would cover all these things, physician, hospital, and also long-term care services and supports. And Blahous, Friedman, and Galvani admit utilization increases due to long-term care. Galvani also limits their utilization to just physician and hospital. They don't talk about any other utilization that's included, dental, vision, hearing, that sort of thing. And so again, you look at the Pollin and the Liu and Eibner ones, and they have increases that are more comprehensive, more consistent with what the bills have. And then the final utilization issue is again Holahan, and we really can't tell very much about this. They don't disaggregate their 16.9, so we really don't know how that was arrived at. So it's really impossible to evaluate and compare. But one of the things we do know about is that it's really high, and it's high even with a supply constraint. There was a paper that was done by Kai et al., and they reviewed 22 estimates of spending over the last 30 years that had some sort of a single payer policy that was being evaluated. And only 3 of those 22 did not predict savings in the first year. And none predicted savings that had increases over 8%. So it looked to me like the Holahan et al. Paper or estimate was very much an outlier. And so we have to take that into consideration. So here I'm going to summarize the adjustments that we made. What would be the reasonable ones to include? We'd want to exclude Holahan because we really don't know how these estimates were done, and it looked like it's an outlier. If we count BIR, if we don't count BIR savings, that's going to increase the spending by some of the papers that included BIR savings incorrectly. And we need to correct for those papers that used the assumption of 6%, because in the bills, at least the Jayalal's bill, the one from that came out of the House, they don't have any role for private insurers at all. So after these savings, the savings would average 6.5% after we made these 2 adjustments, and I'll show you that. Here's the adjustment now for the BIR adjustment. As you can see, spending here would go up by 146 billion for Pollin, and go up 192 for Friedman, and go up 62 for Liu and Eibner. For the BRR, Oh, this is for the administrative cost. Administrative costs would go down here now, minus in the Blahous one, and it would go down for the Liu and Eibner. So overall, if you had this, you'd have these be the new numbers for the percentage change. And as you can see, you have a change in minus, a reduction in the Friedman article of 14.7, and you have still an increase in 7.5 for the one that came out of the Rand Corporation. Now, making the adjustments for the prices, again, we assumed, or that Liu and Eibner assumed prices were constant. Friedman assumed that there would be a 16 or 18% decrease due to prices. You had fairly consistent for the other three studies. 9.5% is the average, so substitute that for the Liu and Eibner would increase the savings. Substituting that for the Friedman would decrease the savings. And here's those numbers right here. There's the decrease in savings from having a larger amount of spending. Here's the increase in savings from having less spending. Blahous, Friedman, and Galvani have these increases in utilization, but they don't include long-term care spending. And Pollin and Liu and Eibner are comprehensive. They have 12 and 11.7. So if we substituted this 11.85 into the Blahous Friedman, increases would increase Blahous by 108, Friedman by 48, and Galvani by 313. And here's that line right here. This is the increase that you'd have due to including expenditures for the long-term care services. So with all these adjustments, the range in percentage change in national health expenditures for all the 5 reports that we have good data from now range from 2.0% to 5.1%. And so the overall average annual savings is just over 3.9% of national health spending, or about 4%. And that's the numbers at the bottom right here. There are some limitations. The size of the price change is unknown. And this is really something we really don't know what's going to happen. Medicare prices are politically determined. So we don't know whether the United States would act like the rest of the G7 countries and have lower prices, or whether there'd be American exceptionalism and we'd still have high prices. As I say, there's a lot of people, a lot of recent studies that have been written on the importance of prices. And again, we really don't know what's going to happen. On average, though, the numbers, I think, for 3 of those studies have been pretty consistent. Another limitation is that we don't know much about the microsimulation model. We don't know how the analysis is done, much about the assumptions. We can't really evaluate the different components like we did with the other approaches. Another one is that there's a political bias here in probably all these reports. Some want to show that the Medicare for all is super expensive. Some of them want to show that it's not so, and that actually saves a lot of money. And so the political bias is in there. And what I've tried to do is try to be as politically unbiased as I can, in evaluating that. And so there are changes that I would make that increase the spending that's associated with Medicare for All, and some changes that would increase the savings. Many of the implications of Medicare for All are not addressed in any of these studies. Some of the studies actually do look at the federal funding increases. Not all of them do that, but there's a large amount of federal funding that would have to be found through increasing taxes in some way, or borrowing, and that's not addressed in this paper. The transition costs, the disruptions, the supply constraints, all those things are not addressed. How that would work in this paper. I've tried to look at the steady state, which is after all those things have occurred. Another thing that hasn't been talked about is, the reduction in the uninsured and the number of uninsured. This is, of course, the reason why you have Medicare for All, and it's the benefit of that. You have a benefit of a reduction in the number of uninsured and underinsured with a savings of almost 4% of spending. That's a good deal. And of course, there's the impact of this reduction in the uninsured on mortality and morbidity. There would be improvements in mortality and morbidity that aren't addressed by these studies. Well, I'm going to stop there and address any questions that you might have. So I'll turn it over to, I think, Anne. Anne, are you there?
I am here. Jen and I, and maybe Mark, you could also look at the questions, and we'll see if we can pick some representative themes here. One is a question about private insurance, and wouldn't the large health systems collude with the insurance companies to treat patients not covered by private insurance? So that's a policy question and of course a fact question. Do you have a good response?
I'm sorry, I didn't quite understand the question.
How would private insurance actually be eliminated?
Oh, yeah.
I can comment on that too if you want. But.
Well, it actually probably wouldn't be eliminated if, in this sense, the way that it works right now is that Medicare contracts with the private insurance companies to do a lot of the claims processing. And so there'd be some of these functions that would not be actually performed by the government, government bureaucrats, but would be farmed out to probably the insurance companies. But of course, that would be a very, very small portion of what they do now. There would be nothing other than just paying the claims and that sort of thing. So it'd be a much limited role.
You're talking mostly an administrative role, not
yes,
not a coverage.
Yeah.
So by policy, HR 1384, now 1976, eliminates private insurance coverage for any covered service under a Medicare for All and improved Medicare for All. And the benefits are vastly improved under Medicare for All. So there's very little role for private health insurance covering patient care,
right,
in the future. And also, it should be understood that hospitals get, am I right about this, about 60% of their revenue is already public sources. Private insurance really covers a less of their revenue than people think.
Yeah, that's right. I can't remember what the numbers are, but that sounds about right. 55% is the one that I would think is true, but I might be wrong. That might be outdated numbers.
From listening to a lot of budget talks when I was a manager.
Yeah.
Yeah. So there's a lot of angst about that. You mean I wouldn't be allowed to buy private? No, you wouldn't need it, is the point.
Yeah.
Let's see. And there are, if health systems refuse to accept patients unless they were covered by private insurance.
I'm sorry, say that again, please.
So if health systems, if these big health systems refuse to accept patients unless they were covered by private insurance, where would they go? Well,
where would they go if you didn't have a health system?
If the health system refused to cover them.
Oh.
It's kind of a moot point, but I think she's referring to, the questioner is referring to the former, or the CEO of Mayo Clinic at one time said they would prefer private insurance coverage over public programs like Medicaid and Medicare. It created some buzz at the time that he said that.
Yeah.
You remember?
I don't, that's kind of a what if question. It's hard to imagine that people would, I mean, it's the only game in town. It's Medicare for all. And so, the alternative to not supplying care to people is to, for physicians to do something else. They could become health economists or accountants or whatever it is. But it seems like, that's a fairly extreme thing.
A question is, one of the questioners asked, did any of these studies or evaluations take into consideration any of the cost changes or savings for hospitals and facilities who are covered under global budgeting, a global budgeting system, as is required in or provided for in the House version of the Medicare for All proposal? Yeah.
I don't know about that. I don't think that there, I don't think any of the states has any sort of a system where they have a global budget like that. The only one that I would think about is Maryland, that has something that would be rate negotiations, but I don't think there's any place in the United States. I might be wrong about that, but I don't think that there's any place. Canada, of course, does. All the Canadian hospitals are paid on that sort of basis, on a global budget basis. So that's when, in November, December, when they run out of money sometimes, and they don't provide the services. But I don't know if that's any place in the United States.
Can you define again the acronym BIR?
Yes, business and insurance related, business and insurance related. And it refers to the costs that the hospitals and clinics have just to get the money from the insurance companies. They have to submit forms in order to, get paid for each one of the patients that they see. And so whatever those forms are, somebody has to fill those out. They have to be submitted. The insurance companies look at those forms and they say, well, these forms I'll pay, these forms I won't. The forms that they won't, they get bounced back. And then the clinics then have to, resubmit them, or, make sure the codes are right, or whatever it is. All that is a huge amount of money used. And as I say, if you look at the study by Jim Kahn out at the University of California at San Francisco, he thinks it's about 20% of total expenditures.
Yes. Do you have a comment about the Yale study? I know that's gotten some press, and was it newer and not included in your list, or is it?
Well, are you referring to the Galvani article, the one that's?
Oh, is that
Yeah,
also known as?
yeah, that's the
Oh.
Galvani article.
Okay, gotcha.
And yeah, the comment I would make is that I'm actually surprised that they didn't include long-term care and other sorts of
Okay.
utilization expansions in their study. What they do in their study is they have they make it so that if you have different assumptions, they have a model that you can download and put in whatever assumptions you want to make about that and find out what Medicare for all would cost if you had those assumptions. But it seems like the one that they should have led with was one that was comprehensive enough to include all the things that were in the bills, all the things that were covered in the bills.
There's a question about increased utilization. I assume that means of healthcare services. Can any comparison be made around other developed countries who have adopted a universal healthcare system?
Sure.
How does that affect?
Yeah, that's, you know, I haven't done this for a couple of years, but the last time I looked at this, it was phenomenal. You had the G7 countries, the other G6 countries. They had half the per capita spending that we did, but they went to the doctor twice as often, twice as frequency per person. They were in the hospital almost twice as many days on average. So the utilization is almost twice as much, even though the costs are half as much. Mm-hmm. So what does that tell you? It tells you the prices are important.
Well, it also tells you that we have a lot of people who are left out in this country. Yes. The numbers are something like 1 in 4 people don't, 1 in 3 to 1 in 4 people don't get the care they need right now. And 1 in 5 people can't afford to go to a dentist. So the savings we will see might not sound really exciting, but we have to remember that we are going to be providing an enormously better services to our population than we have today. Right. We will insure 30 million people who have been left out. We will help people who can't afford because of out-of-pocket costs to seek care. My comment, thank you, my editorial comment.
Dr. Nyman, we just had a comment or a question, and I think this speaks to the utilization conversation that we're having here. Our question is, under Medicare for All, would communities have any recourse when healthcare systems announce the closing of hospitals? I think this also goes along with if there are no global budgets and going with the utilization. Can you speak to whether we would see rural and urban hospitals closing and changing which communities are served? Could you speak a little bit more about that?
Yeah, I think that's a really good question, and I really don't have an answer for that. And it's one of those things that, you know, when I think about this, I think about how people would respond to this. One of the issues is that a lot of the expenditures that hospitals have are determined to a large extent by how much they get paid. And so if they get paid less, then you think there's going to have to be some response. And one of the responses could be that the hospitals close. Another response would be that their expenses go down. The nurses and whoever works at the hospital gets paid less, that sort of thing. So I'm really not sure how that's going to play out. And but it has played out in other countries where the prices that hospitals get are much lower. It's just a question of how, what's going to give, I think, probably.
My read of HR 1384 in 1976 is too new, so there aren't any studies there aren't any good comparisons right now between the earlier bill and the new one yet. It's just out. I mean, the ink isn't dry on 1976. So, but 1384 specifically provides for rural hospitals, smaller community hospitals, and hospitals in urban underserved areas to assure that services are provided and remain available to those communities and populations.
Okay.
What happens to health insurance? There are a couple of questions on how would the coverage change for employers who currently pay employment-based insurance. Would that money be then funneled to help pay for a national health system, a Medicare for all system somehow?
Again, I wasn't sure what the question was.
A couple of questions on the current payroll tax, some of which goes to fund traditional Medicare. And we already know, for employment-based insurance, their benefit package is going to buy policies. Will there be capture of some of that?
Yeah.
When this gets into how are we going to, not how what it costs, but how are we going to pay for it?
I mean, there's a lot of, there's a lot of different sources of money to pay for it. It could be, changes in those taxes, but it could be other sources. And some of these studies actually look into that and try to estimate what would be required in order to come up with the money that was necessary to cover this. I think generally, though, and this is something that I've never been able to understand, I would think that businesses are probably going to benefit from this because even though they do pay greater taxes, they don't have to pay for the coverage of health care benefits. And, if there's a reduction in costs, they're going to benefit from that. So I think that there should be at least some strong interest by the business community in Medicare for all.
Jen or Mark, do you see anything I've missed that we are, and well, then we'll let Dr. Nyman off the hook for fielding all these questions.
It's okay.
Sure. I was just going to say, we have a couple of additional questions, one of which is just talking about how prices are set for Medicare. You described it as being politically set. Are the adjustments that reduce the prices, I guess, could you speak a little bit more to exactly how Medicare prices are set and how that would continue within a single payer system?
Yeah, I'm not sure I have very much to say about that. I think that this really is the crux of the question, though, how these prices would be set. Let's see. It seems like in the other G7 countries that the interests of the various groups have not been marshaled to raise the prices that are paid by the governments of these countries for the services. So for some reason they were able to do that. And as I say, I don't know what would happen in the United States. We could be an exception. There's a study that was done by McKinsey in the early, I think 2000, something like that, that made the point, and I think this is the correct point, that we might not be like the other G7 countries because we're richer. And if you have more income, you probably would have higher prices than the other countries in the G7 that don't quite have the per capita income that the United States does. That's changing, of course, all over the time. But what they were saying was that, you know, there's sort of a level of prices that you wouldn't drop below because the United States, in the United States, people have a higher average income level than in these other countries. That's the only thing that I can think of.
I'll float one more here. Somebody asked about the cost of medical school and the need for physicians to make higher salaries because of paying off medical school debt. Are there provisions, policy provisions that you know of in any of these?
Yeah, I'm not sure about those policy positions. In the other, most of the other G7 countries, medical school is free.
Mm-hmm. I think it's one of my read of this issue is it's one of the policy decisions that has to be made. You know, in the final negotiations for these bills are nowhere near done.
Yeah.
And I'll comment. There's a question about global budgets for hospitals and physician practices. My understanding of global budgets is, according to 1384, facilities of any type would submit their costs and their actual operating costs and be funded by a national health plan based on what it actually costs them to do business. Capital expenditures are a separate application. Just
okay.
To answer that question. Should we, we'll go ahead and thank you so much, Dr. Nyman. This was interesting, informative, and a lot of content.
Okay, good. Here's my contact information.
Okay.
You can reach me at nyman001@umn.edu.
Okay. I will maybe you could stop share and we will end with a few announcements. Just for anybody who's interested. For anyone who's interested, the current legislative session ends May 17th. There weren't any really large health policy issues or bills for us to advocate this session. The Minnesota Health Plan was reintroduced this session in the state legislature. I have the new bill numbers for that on my next slide. At the state level, the Medicare for All Act of 2021 was reintroduced on March 17th, and the new bill number for that is 1976. What we know about the Senate version is that it's soon to be reintroduced, and that there are still some discrepancies between the House version at the federal level and the Senate version. So a lot of work would have to be done to iron those out. There are 115 co-sponsors for the Medicare for All Act of 2021, Pramila Jayapal and Debbie Dingell's bill. That's the highest number so far, but only one member of Congress in Minnesota is signed on to that bill, and that is Ilhan Omar, CD5. So we have activists with Healthcare for All Minnesota who are working to influence that, and we invite everyone to contact their member of Congress and ask them to co-sponsor HR 1976. Healthcare for All Minnesota will be holding a walk, run, bike, swim virtual fundraiser, which will kick off the weekend of May 15th and go for about a month. So look for instructions on participating in that and inviting your friends to participate. Save the date for a fundraiser with Wendell Potter, who will feature as our featured speaker. That is June 22nd. Wendell Potter is our hero for blowing the whistle on the commercial health insurance industry. And he spends a lot of time and energy also working on trying to address the problem of money in politics. So June 22nd. Our next quarterly meeting is Saturday, June 12th, and that's a Saturday morning, 9:30 in the morning. Please, again, submit any events that you have or that you know about to our website, and check our calendar for events and meetings. Also look for your in your inbox for the sender is Healthcare for All MN, and also check our website for additional resources in the toolkit. And please, again, go to the chat and sign in on the electronic sign-in form. It should be at the top of the chat. This slide has the new bill numbers for the Minnesota Health Plan. There are sponsors on both the House side and the Senate side, and also the new bill number for the federal bill, and S1129 hasn't changed yet, the Senate version. Just a few tips for following legislation that I will include. Will it be included in your post-meeting email so you can take a look at those websites? And again, websites and information for you to learn more about it and also share with others. Highly recommend Senator Marty's book if you haven't yet read it. And I also highly recommend a new book called Medicare for All, A Citizen's Guide by two young physicians. It is excellent. I am almost finished myself, and just really one of the best things I've read so far on the whole issue of transforming how we pay for healthcare in this country. Websites of some of our national organizations involved in Medicare for All. And I will also pitch that website on the very bottom for the one-payer states. They have worked really hard on the website. There's a lot of good information on that. These are all the states around the country who are working on state-based health plans. That's just my contact information, and I will invite our panelists to make any last comments if you have them.
Just thank you so much, Dr. Nyman, for joining us this evening. It was a great presentation, and we hope that everyone enjoyed their time with us.
Last call, Dr. Nyman, Dr. Brockie. Otherwise, Jen, I will let you wrap up for us.
Well, thank you so much, everyone, for joining us on behalf of PNHP Minnesota, Healthcare for All Minnesota, and the Minnesota Nurses Association. We thank you for joining us this evening. If you have any questions, please feel free to follow up. You will be receiving an email sometime within the next couple of days, including notes from this evening and a link to the video of the presentation as well. If you have questions, please feel free to reply to that email, and we look forward to seeing you at our next presentation and in June for our evening with Wendell Potter. Thank you so much.